Good evening, everyone. Diabetes is a growing health issue globally, and India is no exception. Currently, an estimated 77 million adults with the age of 18 in India are living with diabetes, making it one of the country's most pressing public health concerns. Beyond blood sugar control, diabetes often affects other vital aspects of health, including lipid metabolism and cardiovascular well-being. Understanding how these factors are interconnected is crucial in managing condition effectively and preventing future complications like atherosclerosis. Today, we are honored to host Dr. Bipin Kumar Sethi, an eminent endocrinologist with decades of experience in diabetes and metabolic disorders. Dr. Sethi will be provide us with valuable insights into complex relationships between the diabetes, lipid metabolism, and atherosclerosis, helping us better understand how to protect heart and overall health. Dr. Bipin Kumar Sethi is an esteemed consultant endocrinologist currently associated with Care Hospital, Hyderabad. Dr. Bipin holds MD in Medicine and a DM in Endocrinology from prestigious PGI Chandigarh, where he was awarded the Silver Medal for securing the first rank in his MD. He has served as a professor of endocrinology at Gandhi Medical College, Hyderabad, and is a life member of ESI and RSFBI. With over 5 decades of experience in the field of diabetes and endocrinology, Dr. Bipin has contributed extensively to medical research with his 24 national and international publications to his credit, and has served as principal investigator in multiple clinical trials. Today, he will be shedding light on an interconnected topic like diabetes, metabolism, lipid metabolism, and atherosclerosis. So before moving forward, Doctor, would you like to add something on?
Well, I think it's well known that diabetes, as you mentioned, is a very prevalent condition, and we had been treating diabetes for a long time as a disorder of intermediary metabolism, which means that the emphasis should not just be on the glucose control, but also other comorbidities and other metabolic abnormalities that are associated with diabetes. To quote Professor M.B. Sahuja from AIMS Delhi, he would say that let's stop treating patients as bags of sugar. And I think that's more appropriate, having known that this statement was made in the pre-statin era. It's very, very relevant and important to realize his vision and foresight in management of lipid disorders, even when we did not have effective medications for treating lipid disorders. Macrovascular disease is a major cause of morbidity and mortality in diabetes, and one of the major factors that has led to its reduction or amelioration is aggressive lipid management. So I think it's appropriate that we chosen this topic for discussion, and I'm to contribute to this aspect of diabetes.
Thank you so much, Doctor. With this, we'll start with the conversation. Doctor, my first question to you would be: how does having diabetes increases the risk of heart disease or blocked arteries?
Yeah. So the atherosclerotic cardiovascular disease, as you rightly mentioned, the disease wherein you have got a progressive occlusion of the vessels supplying to critical organs like heart, brain, or the extremities. And diabetes can contribute to this in multiple ways. Diabetes is a procoagulant state wherein there is increase in the layman's term thickness of blood and tendency for this to coagulate. Diabetes associated also with lipid abnormalities, primarily increased triglycerides, low HDL, a qualitatively abnormal LDL. This is what is called the atherogenic diabetic dyslipidemia, ADD, low HDL, high triglycerides, low density lipoproteins, which are small dense lipoprotein. They may be quantitatively normal but qualitatively abnormal. So this dyslipidemia, there is also association with hypertension, and Diabetic patients can, at some point or the other, have associated renal abnormalities, which can also lead to a dyslipidemia. Obesity, in and by itself, can also further contribute to dyslipidemia. So, all these factors, primarily hypercoagulable state, the dyslipidemia, hypertension, associated kidney disease, and disorder of the vessels, as in the vessel walls inner lining, which is called endothelium, having endothelial dysfunction. So all these factors together with various contributions of the sorts do contribute to accelerated multisegmental atherosclerosis in patients with diabetes. All of us, actually, as we age, tend to have this progressive blockage of the vessels. So, this is an age related phenomenon. And this phenomenon is exacerbated, occurs at an earlier age, and leads to premature atherosclerotic cardiovascular disease related events like stroke, myocardial infarction, and sometimes sudden death. And now people are saying that certain aspects of heart failure can also be attributed to this.
Thank you, doctor. Doctor, my next question is: can high blood sugar affects the way our body handles?
Well, it's actually the other way around. What happens is that both hyperglycemia and dyslipidemia, which I just mentioned, are basically on account of inefficient insulin action. So if you have to just carry this little bit backwards, excessive adiposity in the body, that is excessive fat in the body beyond the stores and subcutaneous tissues, leads to spillage of this fat into the liver, into the pancreas, into the heart, into the muscle, and causing this organ dysfunction of all these organs. So therefore, common thread that is there in this is excessive calorie consumption, decreased physical activity, excessive adiposity, and this adiposity then spilling over into other organs, causing dysmetabolism, that is diabetes, dyslipidemia, then associated things like hypertension, kidney disease, heart disease. So these are actually having a common bearing wherein you have excess body fat, which is not stored in the side. It's like the money you have. If you put it in the bank, then it's good, there's no problem. But if it is in ectopic sites, like in the walls of your library or wherever else, then it's an issue. So I think both the things are common. So high blood sugars do not, in and by themselves, cause disorders of fat metabolism, but they are intertwined and interlinked with each other. With diabetes, you have got a tendency for glycation, which is changing of the proteins of the cells, which is called glycation. So these advanced glycation products can also contribute to atherosclerosis and then can worsen the impact of the dyslipidemia that you have. But diabetes and these lipid disorders, they often coexist and they have a common causation.
Thank you, doctor, for this clarification. As we are talking about the atherosclerosis, so my next question is: what are some early warning signs of atherosclerosis that people with diabetes should watch for?
I think that's a very important question. As I mentioned earlier, that atherosclerosis involves the vessels that supply blood to organs, and for us today, the organs in question are the brain, the heart, and the limbs. Of course, you can also have abnormal blood supply to the gut vasculature called splanchnic circulation. And therefore, if you have narrowing of lumen of these vessels, you will definitely not have adequate blood supply, especially at times when the increased blood circulation is necessary. For instance, when somebody is walking, the heart has to pump more blood, and if its circulation is compromised, then it will manifest as chest pain, shortness of breath. Chest pain is called angina. Shortness of breath is an angina equivalent. Some people, they may not perceive pain because of autonomic neuropathy, or they may have pain in the jaw, or they may have pain in the stomach, the pit of the stomach, wherein you have more pain, which is a symptom after food, taking after taking food, getting some pain, because these are all symptoms when the heart has to function more, it's not able to function. So you can have initially these symptoms on exertion, or when more work is being asked from the heart. But if the symptoms are very severe, you can even have rest pain. So these are not early. The rest pain is not an early symptom. The early symptom would be shortness of breath in climbing stairs or doing the usual exercises, and having difficulty in breathing, or maybe jaw pain, etc., when you are having to exert yourself. For the limbs, when the person is sitting quietly, the blood supply may be adequate. When the person is walking, more blood is required by the muscles there, and you may not then be able to supply blood if your peripheral arteries are diseased. So you walk for a distance, and then you have a cramp in the leg, because that is not the blood cells are not getting as much blood as they require. So the person has to stand for some time, and after a while it goes away, and then he walks for that much distance again, only to experience the same cramp. So this is called claudication, intermittent claudication, which means that this is coming on exertion. Similarly, blood supply to the brain, when it is intermittently being obstructed, you may get what are called transient ischemic attacks. That is, you have a person experiencing a sudden weakness of any part of the body, or sudden loss of sensation. So these are early features which should not be ignored. And if you have this, then I think the person should seek medical attention. As mentioned earlier, far advanced disease can lead to rest pain in the chest for the cardiac tissue. For the legs, there can be rest pain, and somebody, if they have occlusion of the vessels completely, you can have an infarction, what is called an attack, with a brain attack or a heart attack, or even a leg attack, when the person is having critical injury to the areas affected, because there is hardly any blood supply over there.
Yes. Doctor, are there any specific foods or habit that worsen both diabetes and atherosclerosis?
Well, as I said, if we are eating in moderation, then it is not something that is going to cause a disease unless we are genetically predisposed. Hyperglycemia, or increased blood glucose, can happen if we consume foods which are higher in carbohydrate concentration, which do not have much fiber. What we say, foods with high glycemic indices, they can cause increase in blood glucose. As far as the atherogenic diabetic dyslipidemia is concerned, apart from triglycerides, which are dependent on glucose or carbohydrate intake, as also the fat in the diet, the cholesterol in and by itself is largely genetically determined, and it's not possible for someone to increase cholesterol simply by taking diet. It is true that somebody has got high cholesterol levels. We do tell them not to take organ meats, or to take seafood, or to decrease the non-vegetarian food or the egg yellow. But in and by itself, these foods will not contribute significantly to diet. So if you're taking it the other way around, triglycerides can be reduced to the extent of 25 to 40% by dietary modifications, whereas LDL cholesterol, the low density lipoprotein, which we will be talking about subsequently, is hardly ever influenced more than 10 to 15%. So while diet can worsen glucose levels, diet can worsen triglyceride levels, and then in turn the triglycerides can then lead to decrease HDL and increase small dense LDL, which are both dangerous, because HDL is cardioprotective, but when it is decrease in concentration, when you have got small dense HDL, it is cleared from circulation very fast. So the protective HDL is lost. Whereas the small dense LDL have got greater residence in the vessels, they tend to get oxidized, they tend to get glycosylated and be more atherogenic. So when you have high triglycerides, you have a dual trouble of, or double trouble of, low dense LDL being having greater residence in the blood. These are atherogenic and dangerous, and HDL, which has got a smaller residence in the circulation. So the protective cholesterol comes down, and the dangerous cholesterol tends to persist in circulation, get glycosylated, get oxidized, and become more atherogenic. So that is how the diet might influence the hyperglycemia and atherogenicity of the blood.
Thank you, doctor. So my next question to you is: do all people with diabetes need to take cholesterol lowering
I think this
medication?
is a very interesting question. Well, let's go back a little bit in the history. When the statin trials were done for the very first time, they were done in individuals between the ages of 40 to 75. So we have sufficient evidence in the effects of these drugs in people with the ages of 14, between the age of 40 to 75. So the evidence is below 40 does not exist in as much of a volume as it is there for 40 to 75. And also, since very few people used to live beyond 75, the data beyond 75 is also limited. So this is what we'll keep this in the background when we discuss. So it is now felt that we'll talk about the type 2 diabetes first because that is more prevalent. That any type 2 diabetic who is up to 75 years must receive statin, and this is a moderate intensity statin if there are no risk factors. We'll highlight both these things. What are the risk factors? Risk factors are smoking, hypertension, family history of the disease, cardiovascular disease, kidney disease as evidenced by low GFR or eGFR of less than 60, albumin losses in the urine, and age above 60 for men and below 55, above 55 for men and below 60, above 60 for women, if they have had a premature cardiovascular disease in the family. If these risk factors are present, that means the person is at a greater likelihood of having an atherosclerotic cardiovascular disease, and in that case, the intensity of statin should be high intensity statin. What do we mean by that? When we give a high intensity statin, we want and we try to decrease the LDL concentration by more than 50% of the baseline. So you do lipid profile, let's say your LDL is 150 and you have to bring it down by more than 50%, that means you would try to bring it down to less than 75. Moderate intensity statins are, on the other hand, when you want to decrease the concentration by 30 to 50%. In the same example, you would give statins to a person who does not have risk factors to lower the LDL concentration to, let's say, 100 or 75. So by 30 to 50%. I forgot that in the risk factors, LDL more than 100 also is a risk factor, apart from smoking, hypertension, family history. So you have to then, between 40 to 75, depending on the presence or absence of risk factors, either you give moderate intensity statin or you give high intensity statin. Above 75, it is not that you should not be giving. You discuss with the patient, and if the patient is already on treatment, you continue. This is for primary prevention for a person who has never had any cardiac event. For people below 40, you have to start statins if they have a risk factor in the moderate intensity. So we just complete the spectrum. Now below 40, moderate intensity statin if you have risk factors. Above 40, moderate intensity statins till the age of 75 if the person has no risk factors, and high intensity statin if the person has got risk factors. For type 1 diabetes, duration of diabetes is actually considered more important. Wherein it occurs generally in younger people who are otherwise also not that prone to atherosclerosis. Supposing some child has a disease from the age of 5 years. He is not prone for atherosclerosis at the age of 5 years because it's an age dependent process also. So they say that if somebody has got diabetes of 10 years duration or more than 20 years duration or end organ damage like retinopathy or kidney involvement, then they should be getting high intensity statin. So type 1 diabetes is slightly different ballgame altogether, but for the more prevalent type 2 diabetics, almost all people should receive statins. The importance or the benefit of these statins is not so clear in patients who are undergoing dialysis. Not because they won't get benefited, but because the trial that was done did not show the benefit because these people have otherwise also a fairly high chance of getting a cardiovascular event. So these are people who never had a heart problem. If somebody already has an atherosclerotic cardiovascular disease, they are candidates for high intensity statin right away. So answering your question, I would say that most diabetic patients would require statins of some sort, and the intensity of that will vary depending on the age and also on the risk factor that the person has for atherosclerotic cardiovascular disease.
Thank you so much, doctor, for this detailed explanation. My next question is, what steps can someone take to protect their heart if they already have diabetes?
I think these are very, very relevant questions. One thing is that we talk about what the person can do, what the drugs he should seek, and how can they live longer. Diet modification, exercise, control of blood pressure, but even before that, omitting smoking. Taking alcohol also does not benefit the heart. It can actually worsen the atherogenic diabetic dyslipidemia, so they should not take that. If somebody has got hypertension, good control of blood pressure. Dyslipidemia we just discussed, we should take measures to control or lower the LDL levels at least 50% or more because these people are already having a disease. If this cannot be achieved by statins, you can give acetamide, this can be you can give bempedoic acid. Statin intolerance is quite rare, but if that happens, you can always use the lowest possible dose of statins, ezetimibe, bempedoic acid, and in patients who have problems, you can also use problems reaching the target or have got fairly aggressive disease, you can use PCSK9 inhibitors or inclisiran. So these are agents that can be used. Good glycemic control. Now here comes the role of certain drugs which are good for atherosclerotic cardiovascular disease. In that category, we have got GLP-1 analogs like liraglutide, semaglutide, tirzepatide, and usage of drugs like SGLT2 inhibitors are also known to decrease the incidence of major adverse cardiovascular events, as also heart failure and progression of kidney disease, which is quite common in these patients. If somebody has got associated kidney disease, especially if they are diabetic and they have proteinuria, it is also important that these people should receive non-steroidal mineralocorticoid receptor antagonist, which is called Findernon. If somebody has heart failure, again, they should be receiving drugs called like ACE inhibitors or the sartans like ARBs or angiotensin receptor blockers, either of these two. They should also be getting beta blockers, diuretics, and again, drugs like Findernon and SGLT2 inhibitors. So if you have had the misfortune of suffering an event, then preventing the second event from happening is important by way of stopping smoking, controlling hypertension, using drugs which are like RAS blockade or beta blockers, using GLP-1 agonist or SGLT2 inhibitors, and when indicated, Findernon can definitely decrease the incidence of major adverse cardiovascular events, heart failure, and progression of the kidney disease, as the case might be with this molecule. So it's not that they should give up that, okay, we had this, now nothing is going to happen. Of course, if somebody has got significant blocks, they should, of course, be meeting the relevant specialist for revascularization so that the area can be bypassed either by a stent or by putting a vessel which bridges the block.
Yes, definitely, doctor. Doctor, lastly, do you have any message from your side for our
I
audience?
think we started by stating the same, and I would reiterate that it is important that we provide a holistic approach to patients suffering from diabetes and do not restrict our endeavors to mere glycemic control. So that advice, therefore, includes uh, lifestyle changes, weight reduction. Now we have got a host of drugs which can reduce weight, good glycemic control, addressing lipids even if the lipids are normal. Mind you, we have to treat these people, and you raise a very relevant question: do all people require dyslipidemia treatment? And I said that most people require treatment. Chasing targets, multiple targets, glycemic target, blood pressure targets, lipid targets, and keeping them where they are, and not discontinuing treatment or lowering the dosage when the person has achieved the so-called target, addressing concerns, providing proper advice. And you really raise the important question: can diet change LDL levels? The answer is no. So many people, when we ask them to take lipid lowering drugs, especially statin, they say, no, no, statins are not good. I will try this method of treatment, that method, and that never ever works. So it's important also to take care of underlying other secondary causes like hypothyroidism or lipid disorders. So one has to have a holistic approach, and each person who is looking after diabetes should look beyond diabetes, look at least at hypertension as also lipids, to give these people targets of the kind and type that they should be achieving, so that they can be protected from having a disease which is called primary prevention, or having a second event which is called secondary prevention. So I guess this is the sum total of what I wanted to discuss on the importance. It's important that first we measure them. If we don't measure them, then we will not. And mere absence of dyslipidemia, that is LDL is normal, less than 100, is not a reason for not starting treatment. Most diabetic patients would require treatment, including type 1, depending on the duration of their disease and also presence or absence of comorbidities, specifically.
Thank you so much, Doctor. So, with this note, as we come to the close of today's enlightening session, we extend our heartfelt thanks to Dr. Bipin Sethi for generously sharing his time and expertise. His clear and insightful guidance on diabetes, lipid metabolism, and atherosclerosis has been both eye opening and empowering. We are grateful for this knowledge shared, which will undoubtedly help many better understand and manage their health. To our audience, thank you for being a part of this important conversation. We hope today's discussion encourages you to stay proactive about your health and attentive to changes that might otherwise be overlooked. We look forward to bringing you more such expert insights in the future. Until then, take good care of your health and don't forget to follow our social media platform for more such updates, tips, and wellness inspirations. Once again, thank you so much, Dr. Bipin Sethi, for joining with
Thank you,
us.
Jai.